So hello to everybody. First, I would like to thank Dr. Carlos Erasparalo to bring me the opportunity to be with you today. In this session, we will first overview the operating theater setup and the instruments that will allow us to comfortably and usefully perform a wrist arthroscopy. Then we will move to the wrist arthroscopy portals and see which are their risks. Welcome to this session, and I hope you will enjoy it. Let's first start with the optimal operating theater setup and the most useful surgical instruments. How may we organize the operating theater to comfortably perform a wrist arthroscopy? Let's first start with the patient. He is positioned supine with his arm abducted over an arm table. And two short comments about patient safety. First, never forget radiological patient's protection if we are going to use the image intensifier during surgery. And second, in these pandemic days, in which the patient must wear a mask during all their surgical procedure, we should always take off the metal stem of their mask to avoid any risk of nose burning in case we must use an electrosurgical unit. The usual anesthetic techniques are the regional one or the local on the portals one. We should place the tourniquet near the elbow in order to increase the traction tower efficiency. But we should always be aware that when the elbow is 90 degrees flexed, the tourniquet does not compress the elbow flexure to avoid any involuntary vascular or nerve compression. We recommend to take off the usual surface padding of the arm table to increase the arthroscopic traction tower stability, as most of those towers cannot be fixed at the arm table. These are the most common traction towers in the market. Each one has its differential characteristics and none is absolutely perfect, although the Acumets is perhaps the most versatile, achieving the best spatial positioning of the wrist with little interference with radiological controls. Another very, very important aspect about the traction tower is that they contain a lot of metal, which gets very hot during the sterilization process and cools slowly. So, if we have to perform more than one wrist arthroscopy during a surgical session, we should have available more than one traction tower to avoid any patient's arm burn. We usually attach the patient's extremity to the traction tower over the tourniquet, placed near the elbow. In this situation, when pulling on the fingers, the elbow do not rise and the tractive efficiency is maximal. We do not inflate the tourniquet before having all the setup ready. This process can take more than 50 minutes. In long-lasting procedures, the traction tower itself may compress sensitive neurovascular areas of the elbow and the volar aspect of the forearm. And this is why we should always protect the ulnar and the median nerves by correctly padding these areas. Some procedures may require a lot of equipment, and to achieve a stable environment in the operating room, two are the necessary aspects. The first is that the operating room is not small. And the second is that the setup of all the apparatus is always the same, and that all the operating theater personnel know and master it. Let's see, how do we organize our operating theater? The anesthesiologist equipment is at the patient head level, on the contralateral side to which we will work. The arthroscopy tower is at the height of the patient abdomen with its screen easily visible whether we work from the dorsal or the volar aspect of the wrist. Between the arthroscopy tower and the surgeon, we usually place an auxiliary table to put down all the material connected to the tower. This table should be anchored on the contralateral side to the limb to be operated to avoid that it could bother us when we work on the volar aspect of the wrist. Also, it should not be upward to prevent that it interferes in the correct placement of the image intensifier if required. There is currently a new technology that allows us to work without the need of a large arthroscopy tower, which is replaced by this portable computer. And this is a new concept, which is operating rooms space sparing. The scrap nurse will place her table with all the arthroscopy equipment in a second table level next to the arm table. We like to have a steel tray with the cutting material on the hand table to minimize the risk of puncture accidents, especially when both surgeons are located on the dorsal aspect of the wrist or when the large image intensifier is in place. Finally, the table with the specific osteosynthesis surgical instruments, when needed, should be placed on the third level position next to the table containing the specific arthroscopy material. The image intensifier should enter from the patient's feet. If we work on the vertical limb traction, the arc will be parallel to the floor. And if we work under axial horizontal traction, it will be perpendicular to it. Ideally, the surgical vision in any forearm or wrist rotation. Some complex arthroscopic procedures require two experienced surgeons who must work simultaneously both from the back of the wrist or one on each side of it. Therefore, both spaces must be free of physical impediments to facilitate everyone's task at each step, and both the arthroscopy and the image intensifier screens must be visible to everyone from any location. Let's focus now on the surgical instruments needed for a wrist arthroscopy. We usually use the arthroscopes with 30 degrees angulation, and the usual diameter is 2.3 millimeters. The 1.9 lens is not essential, and it's much more fragile. The scope should be small and light because ideally we should hold it like this so that this finger comes to rest on the surface of the wrist, and it allows us to move within the joint in a fine and meticulous way by just moving the tip of our finger. The latest novelty is the nanoscope. It's only 55 grams weight and it's 1.9 millimeter diameter and it's flexible. Two details about the wrist arthroscopy sheath. First, we must always only use the blunt introducer to insert it. And second, it's advisable to always leave the sheath tabs open to avoid fogging the camera in a so small wrist joint space. It is useful to have several hooks, a small one that is the usual one, and a knee arthroscopy one to manipulate bone fragments. However, the most important thing is to exactly know the length of the tip of our proper hook to be able to measure intra-articular distances and volumes within the joint. Although they are not always necessary, it is true that small joint arthroscopy punches can help us to solve many situations. As the scope, the shaver should also be short, light, and ideally ergonomic. And the cutters and the burrs should also be short. to allow the tip of our fingers to easily control any instrument movement within the joint. Nevertheless, although short, the cutters and the burrs should not be of very small diameter, as they would easily block during dry arthroscopy. That is why we will intermittently inject some fluids into the joint. A simple 50 cc syringe screwed onto the arthroscope sheet is enough for this. Personally, I like to adjust an extension set to the syringe so that changing it when it's empty does not cause involuntary movements to the camera. We do not inject normal saline. We usually use ringer lactate infusion, as this one reduces the risk of intra or extra-articular tissue swelling, and this is a useful tool in long-lasting arthroscopic procedures or when we must combine open and arthroscopic surgical steps. Wrist joints are of minimal capacity, and the suction, even if it's closed, frequently collapses the joint space and prevents easy shaver entry or working inside it. So it's advisable to connect the suction system when the shaver is already inside the joint. We do not use an 11 blade as in knee arthroscopy. We recommend a 15 blade to incise the skin over the joint portals. A thin, straight mosquito will help us to bluntly dissect the portal underlying subcutaneous tissue and to perform a smooth and safe arthrotomy. We will always use one or more needles to find out the correct portal location and to show us in which direction we must introduce the straight mosquito into the joint to avoid any cartilage damage. We should have different sizes of finger traps to adapt them to the volumes of all the patient's fingers. And it's very important to widen them at their base so they do not compress the finger too much, and to completely enter them until the base of the finger to avoid any PIP joint sprain. If they are too large, we can fix them with some steri strips, and finally portals can perfectly be closed only with some simple steri strips. Well, after reviewing how to organize the operating theater and how to increase wrist arthroscopy instruments safety, let's now jump on how to safely establish the most frequent wrist arthroscopy portals. Because all the wrist arthroscopists like to look into the joint through a minimal dimension portal that allows us to access to wide, deep spaces, although sometimes we despise the anatomical structures that are in our way to the depths. And it's well worth it to return to the corpse and delve into the details of the structures that surround our portals, even the most common ones. All the images that you are going to see now correspond to left wrists. We will first review the dorsal radiocarpal joint portals, then the dorsal mid-carpal joint ones, and finally the volar central portal. Let's start with 4 dorsal radiocarpal joint portals. The first one is the 3-4 portal, which is found 1 centimeter distal to the listed tubercle, and we will introduce the scope through it. This portal is located between the extensor pollicis longus and the extensor digiti communis tendons. If we find any difficulty in establishing it, we should always remember that this may be due to the existence of the dorsal radiotracheal ligament. Do not heavily push on your instruments. We will easily solve this problem by increasing the amount of traction. We should be cautious at the level of this portal And we should always perform a blunt subcutaneous dissection until the joint capsule, because the posterior interosseous nerve has multiple anatomical patterns before entering into the radiocarpal capsule. And it's not uncommon for it to elapse adjacent to the portal as a thick nerve trunk, which injury can cause very severe complications to the patient. The second dorsal radiocarpal joint portal that we usually establish is the 6R1. It's located on the radial edge of the ECU tendon, and it's usually set under direct visualization from the 3-4 portal to avoid damaging the TFCC components or entering below its proximal surface. We will introduce our hook through it so that the instrument will enter the ulnar carpal joint space at the dorsal edge of the TFCC to explore the proximal and distal components of the joint. The first anatomical structure at risk around the 6R portal is the extensor digiti minimi tendon, which is very thin and which a great anatomical variability. Therefore, we do not suspend the little finger from the traction tower if needed until this portal has been established. In this way, we avoid the tendon tension, facilitates its iatrogenic involuntary rupture. The second structures at risk are some transverse branches of the dorsal sensory branch of the ulnar nerve. That is why we must only use our 15 blade at the skin level and then carefully, bluntly dissect the supracapsular subcutaneous tissue to minimize the risk of their damage. The third dorsal radiocarpal joint portal that we frequently establish is the 1-2 portal. It's located at the snuff box between the tendons of the first and the second extensor compartments. Also here, we must be very, very cautious with its blunt dissection, as at the subcutaneous level, the portal has the dorsal sensory branch of the radial nerve dorsally, and volarly, it adjoins the unified sensory branch of the radial and the lateral cutaneous nerves of the forearm that give the sensitivity to the base of the thinner eminence. Also at the distal level, the portal is close to the radial artery and its 2 satellite veins. So, although the 1-2 portal is a very useful portal to scope or work at the radiocarpal joint level, it should always be cautiously established, and the portal skin incision should be large enough to insert some retractors that protect from nerve or vascular iatrogenic injuries. The last dorsal radiocarpal joint portal that we commonly establish is the 6U1. We have before seen that the 6R portal penetrates the ulnocarpal joint space from the radial margin of the ECU tendon. Well, the 6U portal does so from its ulnar aspect. To easily establish the 6U portal, the forearm must be rotated in supination. In this forearm rotation, the ulnar stylet is located dorsally and do not disturb the direct intraarticular access. The dorsal sensory ulnar nerve branches surround the 6U portal. To reduce the risk of these nerves injury, we must keep the forearm, the wrist, and the hand in supination, and, if possible, in wrist flexion. So, forearm supination facilitates the 6U portal establishment while protecting nerve injury at this level. Let's now move to the 2 usual dorsal midcarpal joint portals, and we will start with the midcarpal ulnar portal, which is located at the ulnar margin of the extensor communis tendons. at the four corners joint space. We will introduce the scope through it, and the most important MCU risk is to forget that the four corner joint space plane is parallel to the floor. So any instrument must enter into it in this direction to avoid joint surfaces damage. In fact, while in radiocarpal joint, the instruments must be inserted with a 10 degrees angulation through the MCU portal, they always must be inserted in a zero angulation direction. The second MCU portal risk is the injury of some longitudinal sensory branches or some big dorsal veins. These complete or incomplete veins laceration are very frequent and need to use of some full thickness portal points. In those cases, stereo strips are not enough to avoid unsettling bleeding. Let's focus now on the last dorsal portal that I'm going to talk about, the dorsal midcarpal radial portal. It is in line with the MCU1, but at the radial margin of the index extensor digitorum communis tendon. It penetrates into the scaphocapitate joint space and allows us to introduce the hook into the midcarpal joint. It should always be established under direct visualization from the MCU portal because here the joint space is very narrow and the scaphoid and the capitate joint surfaces are at real risk during its establishment. And in the same way, if we are not very cautious, we can injure the dorsal scapholunate ligament or the dorsal capsular septum if our instrument enters into the midcarpal joint too proximally from the radiocarpal one. We have reviewed the most dorsal radiocarpal and midcarpal portals that allow us to see and work on the central and volar anatomical structures of the wrist, but sometimes we need to do so on the wrist dorsal structures, and we will need to establish a safe volar portal. I'm going to talk about the volar central portal, which was published in 2016 by my friends of Madrid, and that has recently been considered as the safest volar wrist portal. Both wrist creases correspond to the radiocarpal and the midcarpal joints. So, with a unique skin incision, we can penetrate into both joints if we center it over the lunate bone. The proximal aspect of the portal will bring us into the radiocarpal joint, while its distal portion will directly carry us into the midcarpal one, without any volar ligaments disturbances. Both portals are located between the FDP tendons of the fourth and fifth fingers ulnarly retracted, and all the other flexor tendons radially, and those tendons protect the vascular and nervous structures. Nevertheless, the midcarpal volar central portal is more risky than the radiocarpal one. The fourth finger flexor digitorum profundus tendon and the ulnar artery are very close to it. I'm not going to talk today about the distal radioulnar joint, but remember that this is another different wrist joint accessible through many different portals, which can also be risky for another day. In conclusion, almost every portal can be risky, but good news are that we can turn them into safe because we can influence over all the anatomical structures that surround them. An excessive traction strains all the cordonal structures and make it easier for them to be cut with our blade or our shaver. So do not put the wrist under a great amount of traction. Forearm, wrist, and hand rotations Modify the spatial situation of all the anatomical structures that cross the forearm rotation axis. So be always aware of the limb rotation. It can help or disturb your daily practice. But the best tool to establish safe wrist arthroscopy portals is our surgical technique. This must always be cautious and systematic. Use your 15 blade only at the skin level, never in the subcutaneous tissue that must be bluntly dissected. During this dissection, follow the dangerous underlying structure axis with your mosquito in order to respect them as much as possible. Avoid tracting from any finger which is not essential to reduce the amount of structures put under tension, and never do without a good assistant and some good retractors. Be consistent and analyze your own complications as we did after our first 50 years wrist arthroscopy some years ago. And above all, listen to everyone who can teach you so that arthroscopic portals complications do not cause the patient any new problems. I really hope that my presentation has been useful to all of you. Thank you very much for your kind attention.